you so much, Dr. Andreski, for coming here and kind of visiting with me. Yeah, of course. So for those who may not have had you in class yet or may not have the pleasure to work with you on an everyday level, could you kind of introduce yourself, talk about your practice, and kind of what you do?
So I'm a second career academic. I'm a practicing pharmacist. I'm Iowa native, Des Moines native. Did my undergraduate training at the University of Iowa. Then I entered a 20-year hospital pharmacy practice degree career. And during that time I picked up an MBA. I was living in Florida at the time and decided to make a little bend in my career. So I went back to the University of Iowa and studied and received a PhD in pharmaceutical socioeconomics, which is a mouthful, and came back to my hometown. When I was a small child, I used to live about 5 blocks west of Drake, so this is a real homecoming for me.
So what kind of caused that idea of coming back and getting your PhD, and how did that spark?
Sure. So at the time I was practicing in a secondary level hospital in the central part of the state, and was heavily involved with clinical management. So I managed the clinical pharmacist, I managed the clinical program at the hospital, I maintained the hospital formulary, and also managed some other teams within the pharmacy department. And at that point I became very interested in the economics and the operations of working on the drug budget in the hospital. And when I would do research into how can you make that process more effective, how can you get the physicians to buy into the treatment protocols and the services, and I found that there was almost nothing out in the literature. And so that was my motivation, that I wanted to go back and research how to make the whole drug medication use process at that point in the inpatient hospital setting a little more effective. And I was, frankly, I was missing the Midwest and decided it was a good combination of things to come back and go back to school and come back to the Midwest.
So on the journey back to the Midwest, you kind of became a professor. So other than your academia responsibilities, what else do you kind of work on?
So in addition to the teaching responsibilities, I do research, and I also work, I've done a lot of research with the Iowa Pharmacy Association. I'm also part of their legislative advocacy group that they're putting together, so we make contact with legislators. So it's basically working on practice issues within the state. So I don't have an actual practice outside of academia, but I look at it as I still have my pharmacy license, I keep it active, I do my continuing education, and it's working in service to support the community pharmacists within the state.
And in your kind of actions of supporting the state and supporting the community, how do you think your background has allowed you to kind of take hold and innovate some of the practices here in Iowa?
So one of the things that I was lucky to be involved with was, as soon as I was a junior faculty member, the Iowa Pharmacy Association was putting together what they called the new Practice Model Taskforce. So the idea there was a group of Iowa pharmacists who happened to have been past presidents of the Iowa Pharmacy Association, and they met on the legendary Bob Osterhaus's porch to share some refreshments. And the question came up was, why is the practice of pharmacy in Iowa still primarily distribution-based? This was back in 2010 when we'd made the transition to full PharmD. We'd had the Iowa Center for Pharmaceutical Care. And so all these actions have been put into place, but there was still a holdup on why was there not a bigger transition to what in that day was a pharmaceutical care model. And so I was able to join that task force at the recommendation of, at that point, Dean Rossbond. And when we got together and talked about things, the idea that the pharmacists don't have a lot of time to do with patient care activities was the focus of our discussion. And I mentioned, well, we've used what is commonly called tech check tech in the hospital setting for years, would that be something that we could possibly apply to a community setting? And the group decided that that would be an interesting intervention to try, and went to the state to get a waiver of the requirement that the pharmacist check the final product, and found that the Board of Pharmacy didn't have the ability to approve pilot projects. So the association went to the legislature. It took 3 legislative cycles just to get a pilot project authority put into place. And at that point, pharmacies were recruited, and eventually we had 17 pharmacies that participated in this project and used now what we call technician product verification. And so the result of the study was we found that the time that the pharmacist had available to work with patients in many instances almost tripled, and the amount of time they spent in dispensing went down significantly, and the number of dispensing errors that made it to the patient were the same as when the pharmacist checked it, and in some instances they were actually lower than when the pharmacist checked it. So the idea was to free up the time for pharmacists to put together innovative services. So I guess that's what I would call my contribution to innovative practice.
And when you talk about innovative services, do you have a couple things in mind for those who might not understand what that means?
Right. So in Iowa, there are 2 initiatives going on currently. One of them is the Community Pharmacy Enhanced Services Network, and that's a group of pharmacists that have, it's a takeoff of a national project that started in North Carolina from another Drake graduate. Troy Trigstead was one of the leaders in that. And these pharmacies agree to offer 6 core services. It's called Clinical Med Sync, was the last thing I think I heard. It's basically taking the medication synchronization idea where patients would get all their medications done at the same time, but on top of that laying on it almost a complete medication review. So not only does the pharmacist work to get all the medications filled at the same time, they're also doing things like assessing the patient's adherence, working with other educational issues. So it's moving the pharmaceutical care model, actually the pharmacist patient care process model into the community setting. So that's an example of one of the services that having that time is allowing these pharmacies to do.
And how do you view these innovative services progressing the pharmacy profession with community and hospital and kind of as a whole?
Right. So there's the idea that pharmacy is bifurcated into these different types of settings is something that we're working to really get past. We really need to look at it as the whole team. What the actions of the hospital pharmacists do, which of course I'm very familiar with from my practice career, it's dealing with those acute, intensive situations that require hospitalization. But think about it from a system standpoint is looking at a circular version of care where the pharmacist is able to prevent those hospitalizations by working with the patients to maximize their medication therapy. But in the instances when, due to interpatient variation or just the disease process progressing, that patients do have to enter the inpatient setting, that once the patients are stable enough to return to their home environment, that then those pharmacists in that setting work with the community pharmacists to have a proper transition of care so that patient doesn't bounce right back. So the idea is to, we both in that circle that everybody practices to the top of their abilities. So the overall goal would be to have, in some ways, the inpatient pharmacists be a little less busy, but the patients that they see, they actually can send out and help them recover their health and stay healthy once they're in the community environment through those transitions of care.
Yeah, I think that's very important too, because it seems like at the community model is you're getting higher star ratings, and insurance companies are paying for more services, so they don't go right back to the hospital.
And that's part of one of the other initiatives in the state is that Wellmark has put together a value-based pharmacy program, and the idea there is they're focusing on 4 disease states, and they're also, what Wellmark is doing is they're looking at outcome metrics that are based on pharmacy practice. A couple of more global outcomes they're looking at are preventable hospital admissions and preventable emergency room visits. And based on those metrics and several others, there's a scoring mechanism, and that those pharmacies are eligible for payments from Wellmark through the medical benefit. This isn't anything to do with dispensing. So the pharmacists that help the patients achieve their health outcomes actually are being reimbursed by a health insurance company for doing those activities. So it's not a fee-for-service type activity, it's a value-based, basically a share-the-risk type of a situation.
And what do you have for advice for maybe students who are coming into the field as new practitioners in community pharmacy, or maybe practicing community pharmacists who see that opportunity but are still kind of stuck in that fee-for-service model?
Right.
How would you help them explore the options of innovative services?
Well, one of the things is, for example, the Wellmark network is it's an entry level, I won't say experimental, but it's a trial program. And one of the things that I would recommend is to don't approach it half-heartedly. It's dive in with gusto and be willing to take a few risks. For years, we as a profession have been wanting to show that we can have a bigger role to play in the healthcare system beyond just dispensing of medication. So we're at a point in the trajectory of the profession that we're being given some options to move into the pharmaceutical care model, to basically go back to what was discussed way back in the 1980s, Hepler Strand and the Hilton Head Conference, which is to become responsible for medication therapy. And when we accept that responsibility with our patients and with our other caregivers, that we can show the bigger impact that we can have, and that we will move from a fee-for-service based, if I fill a prescription, I get paid for it. There still will be some of that involved, but it's showing the value of the pharmacist in doing things beyond that. Frankly, there are going to be more advances in robotics and other artificial intelligence that are going to allow the filling of prescriptions to become more and more automated. So it's time to use and maximize our training to managing patients to a higher ability that we all know that we have. It's time to establish the working relationships with providers and patients, and move into a new paradigm.
Yeah, I think that's very important. And you do have 2 classes that you teach that in here at Drake University, is that correct?
I actually have 3.
3.
Well, I'm teaching 2 and 1 I coordinate.
Oh, okay, got you.
So I teach the management and pharmacy class, and that is we have many students who do a dual degree where they do a PharmD with either an MBA or an MPA. And so what I attempt to do is to take some of the topics that you would learn in the MBA program and give a very high-level overview of how those apply to pharmacy practice. So for those pharmacists in training who aren't taking those programs, at least have some insight into management. The second class I teach is a developing services class, which is basically I do what I did in the inpatient environment and use it in all environments. It's looking at how do you develop the clinical side of a program and then wrap a business plan around that to make it sustainable. And then I also coordinate, we have a series of continuous professional development classes, and I coordinate one of those classes.
So the second class that you talked about, where you kind of develop that service in multiple ways, why do you think that's important for students or even practitioners to be a part of?
Sure. One of the things that I saw when I was in my clinical practice and as a manager was that for pharmacists, activities that you were going to do on a relatively routine basis, so the type of patient that you're going to see on a frequent basis, that to try to design that patient's complete course of therapy from scratch every time was very inefficient and also often wasn't extremely effective. When you have a large number of patients that you're going to see with some similar issues, it's not to say that you cookbook it for everyone, but you put together a plan where you've looked at the research, you know what's effective, you have a plan put in place. So let's say if you're presenting with a diabetic patient who's newly diagnosed, that you have some series of best practices that you can put in place to manage that patient, that you have the resources that you have had budgeted and made available, that you have the support to provide those services, so that when that patient presents to you, you right away can immediately start to take care of that patient. You have the pre-established relationships with the prescribers. You may have a collaborative practice agreement in place, so that when that patient presents, you can right away affect their outcomes positively. Also, when you do it in a planned manner, it allows you to take advantage of budgeting and looking at ways to come up with reimbursements so that that service can be financially stable. So the idea is to have something that takes the ideas of pharmaceutical care, puts a sound business plan around it, makes it replicable, so it basically makes the pharmacist more comfortable providing the service, as well as more effective and more efficient in providing that service.
Speaking of kind of developing process or developing the pharmacy profession, I kind of have a little bit more fun of a question for you. So if in a parallel universe all of a sudden you decided to wake up and you're Surgeon General of the United States, what is kind of the first couple things that you would put in place in pharmacy or in the healthcare system in general?
So since we're in that kind of a situation, part of that continuous professional development class was we talk about the history of pharmacy. And speaking of Surgeon Generals, there was a decision that was made in, I believe it was 1918, where the Surgeon General did not include pharmacists and providers. So if we're going to be in that situation, I go back to 1918 and change that decision. But one of the first things that I would do is make pharmacists eligible to be providers under the Medicare benefit, but that's really not the magic bullet. I think the other thing that I would do would be to work to fully integrate the pharmacist into the more in the clinical side, in the intellectual side. Understanding that pharmacists have a role to play in distribution, but to have the pharmacist be the medication effort. I guess if we're going to be in that type of a situation, I would basically allow that if physicians wanted to, that they would be able to give the pharmacist the equivalent of a prescription that basically said patient has essential hypertension, pharmacist to manage medication therapy, and had to have that reimbursed so that we can take the training that we know, work with our physician and other prescriber colleagues who are skilled at diagnosis and at patient management in a global sense, and work to maximize those patients' health based on that. So it's basically making the pharmacist be able to practice at the absolute top of their training.
And because I've had a couple of people say that as well, having the doctor say patient has XYZ, prescribe something.
Right.
How long, if you could put a time limit, do you think that could ever happen? And if so, do you think it would happen in the next
I think
years?
in the value-based atmosphere, physicians are understanding that outcomes are more of a primary concern than cranking out a number of billable procedures. With some of the changes that have been happening from both the Affordable Care Act and now that some of the private insurers are also looking at value, people in the executive suites of the insurance companies and other levels want to see that the money that's spent on healthcare is spent effectively. And sometimes we don't do that. And physicians they're starting to see that pharmacists can be enablers of their practice, where the pharmacist has the expertise to help the physician with that very difficult patient that takes up an inordinate amount of time that the physician has to invest in taking care of a patient, and realizing that that patient, every time that there's a failure or that the medication therapy or the overall therapy doesn't, let's say for lack of a better term, work, that patient has to come back to the physician's office, which then keeps the physician from seeing another patient. And so realizing that the patient goes to the pharmacy every 30 days, using that pharmacist as a physician extender to allow that patient to get a better outcome from their medication therapy frees up physician time to do a more in-depth diagnostic workup of patients, to have a better working relationship with those patients. And that's something that as physicians are being reimbursed under a care model, they're going to see that there is a financial benefit to working with the pharmacist as well. We're already seeing some beginnings of that even in the central Iowa area with between Clinic and Ames, a local small pharmacy chain, and Drake are talking about embedding a pharmacist in a practice to help that physician clinic achieve some of their value-based outcomes that they're needing to make. So I think it's one of those things that it can happen faster than we ever could expect with the current reimbursement climate in healthcare.
Perfect. Well, thank you so much for taking the time out to kind of come and talk to me about this. Is there anything that you would like to comment on or kind of expand on more?
Sure. Just basically, just yesterday we had a future pharmacy panel with the P1s, and we brought in other leaders from across the state of pharmacy. And one of the things that all of them agreed on was that pharmacists need to not be afraid to talk to people. They need to be willing to talk to providers. They need to be willing to take risks, and they need to establish the relationships in the community so that they can advance practice. So basically the message is get out from behind the counter and talk to people in both patient atmosphere and our other professionals.
I couldn't agree more with you. All right, well, thank you so much, Dr. Andreski.
You're welcome. Thank you.
Yeah.